Hi, everybody, and thank you so much for joining us for our MDA Advocacy Institute Access to Care Affordability. We really appreciate you all joining us this close to the holidays. We've got a really great show for you all tonight between myself, Paul, and our guest, Justin. And without further ado, we will get started. So just a couple of housekeeping things for those of you that might be joining us for the first time. If you need closed captioning, it's over there on the left side of your screen, the little CC box there in the bottom left corner. And then we do encourage you to engage with us through the chat and Q&A functions. The chat is right there on the lower right part of your screen. And then for Q&A, just tap the three dots that are there right next to the chat on the bottom right-hand part of your screen, and you'll see the Q&A that'll let us kind of filter through for any questions you might have throughout the evening. And now I can introduce you, we'll get you through our agenda first, actually, sorry. So we're going to go over proposed changes affecting healthcare affordability across insurance types. So Justin will talk us through changes to the Affordable Care Act and the ACA marketplaces and what that'll mean for affordability. Then Paul will take over and talk changes to Medicaid. I will then take the ball for changes to Medicare and a little bit on ERISA plans, and then some bonus news out of Washington, D.C. over the last couple of days as some really monumental things and impactful things have happened that we want to cover for you guys. So you've heard me say their names twice now, but who do you have with us tonight? You've got Paul Millmeyer, our Executive Vice President of Public Policy and Advocacy. You've got me, Joel Kartner, your Director of Access Policy. And then you've got Justin Giovanelli, who's an Associate Research Professor and Project Director at Georgetown University. Speaking of Justin, just to give you a quick rundown on his bio, as I said, he is an Associate Professor and Project Director at the Center for Health Insurance Reforms at Georgetown, where he studies private health insurance and the Affordable Care Act marketplaces. Justin has written extensively about state and federal policies that affect availability, affordability, and design of coverage sold to individuals and small businesses. He also provides strategic advice and training and technical assistance to policymakers and health insurance market stakeholders. Before joining Georgetown's faculty in 2013, Justin practiced law at a large litigation firm in New York and clerked at a federal district level. Justin holds a degree from New York University School of Law, a Master of Public Policy from Georgetown, and a BA from Penn State. And with that intro out of the way, I will actually hand things over to Justin to talk us through our first topic of the night, which is ACA marketplaces. Justin?
Thanks so much, Joel. It's a pleasure to be with everyone. And one thing I do in addition to that is schlep people around to basketball practice. And so I apologize for my bad lighting and background here. I apologize for any distraction with that. I am kind of doing a little running around with the kids this evening, but I'm happy to join you all this evening and talk through where we stand with the Affordable Care Act marketplaces. There's been a lot going on over the last year regarding coverage through the marketplaces, regarding the Affordable Care Act generally, and I'll hit some of those points here tonight. With respect to the marketplaces, really, because I guess you'll hear more about changes to Medicaid, which have also been significant. So mostly I'll talk about changes, but I think it's actually helpful to talk about what has not changed for the Affordable Care Act for folks who rely on it, who purchase coverage through the marketplaces. So there are significant changes, but the basic consumer protections that have been in federal law and that people can count on through marketplace coverage are all still in place. So health insurers still are not allowed to deny coverage to people based on health status or any other status. You're guaranteed to get a policy. There are no prohibitions or other restrictions on pre-existing conditions. All of these plans still have to cover 10 categories of essential benefits. There are no limits on annual or lifetime how much the plan will pay out. A big thing that I'll talk about in more detail here in a second, financial assistance for purchasing coverage, those premium tax credits. So A lot of how that works is changing. And again, I'll get into that more in a second. But this is important to know that some of those subsidies, those premium tax credits, whatever happens in Washington or has not happened so far, it's not that all financial assistance is going away. It's that a significant amount of it is. So to be more clear, for many people, for probably most folks who have relied on the marketplace, there will still be some financial help in terms of the premium tax credits. Many people will still qualify for help depending on their income for cost sharing assistance. It's not all going away. It's partly changing. So what is changing? How is it changing? So there are really, going to touch on, I'll lump them together actually probably, but three sort of areas where we've seen change in the last year. One is that there was, of course, a very large domestic policy bill that was went through Congress and was signed into law this summer. There are a lot of changes to healthcare in that, to Medicaid and to the marketplaces here. There have been various rule changes made by the administration for how these work. And then third, one big area of change has actually been through inaction with respect to these premium tax credits, where Congress has not done anything recently on that issue, and for that reason, things are changing. Another sort of, I guess, background thing for what I will and won't really get into here. All of those sources of change, some of them are actually are causing changes that won't take effect right now, that will take effect in 2027. Not going to get into those tonight. There are some changes that actually triggered lawsuits and some things that particularly that the administration had tried to do through rules that have been blocked by a court. And I'm not going to really get into those because they're not happening right now. So I'm really going to try to focus on what actually is occurring now and in the coming year. So with all that, from a marketplace perspective, the biggest change, the biggest thing that is going to affect folks, and it's affecting folks already, and maybe some of you, if you use the marketplaces and are shopping there, is the change in financial assistance and how that works. And so, as you may know, so there are these premium tax credits that I referred to before that were in the law from the beginning that make coverage more affordable and are available. The amount that you're eligible for depends on your income, among other factors. And in 2021, a law was passed that made those tax credits much more helpful to folks, much more generous for the people who were eligible for them, and expanded eligibility so that more people, including those at middle incomes, would get at least some sort of help. One feature, if that's the right word, of the way the tax credits worked in the first place is that there was like a cutoff at a certain income, and so that if you earned just over that, you would get no help. That's not the greatest way to design something like this. So the 2021 law that made these credits more generous, much more available, got rid of that cliff, did a lot to help folks be able to afford coverage. Enrollment in the marketplaces has basically doubled since then, and a lot of that is because of this increased affordability. It's been a really big deal. So unfortunately, those enhancements, from 2021, the expansion of who's eligible and how generous those credits are, is as of this moment, is going away. There's been, as you may be aware, there's been a great deal of back and forth, and it's been a very big issue in Congress in the last few months. It's been a big issue really in Washington for much longer than that, but it finally sort of gotten attention from all folks involved in the last few months. But the bottom line for us tonight is that the credits are expiring at the end of the year, and so they will not be available. These expanded, enhanced versions will not be available for 2026 coverage. So for folks who are already on the marketplaces shopping, they're seeing much more expensive coverage, sometimes really tremendously more expensive, unfortunately, and we would anticipate it's going to cause a lot of folks to make some difficult decisions about whether to remain covered and how to approach that. Certainly more to talk about on that, but that's sort of I think the bottom line for now. There is some you may have heard some discussion, some possibility. Could these be kept around after all and extended? You never know. And the way that the tax credit works is that if there could be an agreement reached, then it actually is possible to help the folks who have already signed up for coverage. But my candid best assessment is that probably will not happen. So I would end all of this by saying, for folks out there who are relying on the marketplace for their coverage, and despite all of these challenges with affordability being presented, I think it's really, if you have a plan, it's worth going back and shopping again for coverage and seeing what your options are, and obviously seeing what you can do to stay enrolled as best one can. Other changes that I will just hit briefly, because I think for our purposes tonight, that is the biggest one, but there are some changes from the places I mentioned before and how how it works on the back end to figure out your tax credit eligibility. So as you might know, for those of you who have used it, when you get a tax credit, you have to sort things out during tax time in the following year, because the amount of the credit you get is based on your estimate of your income. The rules around how that works have gotten much more strict starting this coming year. And so people may, hopefully should be making their best estimate for how much income they're earning in the coming year when to figure out that tax credit. But if that estimate turns out to be a little different from what reality is, people are fortunately, from my perspective, much more exposed to having to pay much more back at tax time. So people need to be particularly careful to give their best estimates and to make changes inside the marketplace if their circumstances change over the course of the year. Eligibility for certain groups of people are changing next year on the marketplaces. A lot of some of the new laws and regulations have targeted folks who are immigrants who are lawfully in the country and who have long been eligible for marketplace coverage in stages are going to no longer be eligible for coverage. That's a big change coming up. And then now and in the future, there are elements of the enrollment process that are going to become more challenging with more red tape, some more restrictions on being able to access coverage during the year if your circumstances, for like a special enrollment period. So some more barriers to enrolling in this coverage. So I want to be respectful of time. I'll stop there, and I know I'm in a way just kind of scratching the surface, and there's a lot of other things for you all to cover here tonight, but happy to take any questions from folks, however easy it is to do that here.
Yep, and I can help out with that and kind of skim through the chat and Q&A boxes here. One question from, there we go, from Kristen is, I have long-term care insurance through a Center for Healthy Living, and it's changing from Empire to Blue Cross Blue Shield. Will my Medicaid coverage be affected? So I think that's maybe a window into talking about how various MCO Medicaid plans may be affected by changes in overall marketplace plans. So Justin, I'll let you take the first crack at that before hopping in.
Yeah. I mean, I would defer some of the Medicaid analysis to other folks here who may be able to answer it better. But in general, I do, at this moment, we are not seeing insurance companies decide not to work on the marketplaces anymore. We've seen a lot higher premiums, as I alluded to, for various reasons, but mostly because of the removal of the financial assistance. It's possible that the way these private plans choose to do business might change given some of these restrictions, but we haven't really seen that yet on the marketplaces.
Yeah, and I'll kind of echo that. We'll get into a lot of this later, but based on how insurance companies kind of work together, it's possible that you might see some amount of changes on the edges, but I would find it pretty unlikely, at least at this point, to see any massive shifts in coverage priorities there. Katie Sue has a question. When you refer to immigrants legally in the country, does that include naturalized citizens?
No. So folks who are citizens, their eligibility in this whole scheme is not changing. To give a little more color, what has changed and is changing is that folks who had referred to as DACA individuals, people who had deferred action, can't access the marketplaces anymore. And then a much larger population, people who are actually green card holders, lawfully present folks who at low incomes, who have long been able to use the marketplace because they're not yet eligible for Medicaid. They're they're lawfully present, and they will no longer be able to have financial assistance in the marketplaces starting this coming year. And so that's a lot of folks who have done everything right and are now being cut off.
Well, on that note, I'm not seeing anything new in the chat. And Justin, I know that you've got other places to be, but thank you so much for lending your expertise tonight. And we really appreciate it.
My pleasure. Thanks, everyone. Take care. Happy holidays.
All right. So as you just heard from Justin, there is some outside chance that further action can be taken by Congress to extend enhanced premium tax credits that we just covered. To fully plug into that, you can go to mda.org/advocacy to find our action alert on supporting permanent reauthorization for enhanced premium tax credits. It's a really simple form. We always encourage you to personalize those messages as much as possible, but in general, we can get you through it really quickly, and your voice absolutely still matters in this subject area, as they could choose to reauthorize these at any point before the end of the year. So the fight's definitely not over there for sure. And then thank you, Mark, for putting that link in the chat. You can just click that and be taken right to that action alert. So really, really appreciate you all taking the time to do that. And with that, I will hand things over to Paul to talk Medicaid.
Yeah, thank you, Joel. Good evening, everybody. It's a pleasure to be with you again to talk about the ways in which healthcare affordability, particularly in accessing it through health insurance, are affected by policy conversations, policy changes, policy proposals, largely at the federal level, but also somewhat at the state level, which I'll be touching on here momentarily on Medicaid. We started, of course, with the ACA marketplaces, and that's where we've seen a lot of the conversation of late, as Justin said, and as Joel has been saying, on conversations happening on Capitol Hill. Literally, today there was a really important vote on Capitol Hill just today on these kinds of proposals. So we always try to choose timely topics to bring to you during our advocacy institutes, and this certainly is timely and will remain timely through this month and into next month, probably, maybe even beyond. We'll see. But after having talked some about the marketplaces and the Affordable Care Act, health insurance plans, or Obamacare, we want to also talk some about Medicaid, because we know that Medicaid is incredibly important to those with neuromuscular diseases. In fact, some data that we have shows that the plurality of the neuromuscular disease community uses Medicaid as their health insurer, so more than any other health insurance option out there. So clearly Medicaid is very important. But to move to the next slide, just in case Medicaid might be a bit of a new concept to some, let's just kind of level set on what Medicaid is. So Medicaid is a joint federal and state health insurance program. It's a collaboration between the federal government and each state and territory. And it's a health insurance program that's intended for those with low incomes, for those with disabilities, for children, for pregnant women, and then oftentimes other kind of specific groups might be carved into Medicaid, depending on what the state wants to do. And it really is oftentimes the state that is making the most important and most impactful decisions on how their citizens or just individuals who live in that state are going to experience the Medicaid program, on what's going to be covered at what level and where. Now, the federal government is still important. The federal government pays for the majority of Medicaid. The federal government will pay, generally speaking, anywhere from 50 to all the way up to, sometimes to 90% of the costs of a state's Medicaid program. And as at least in part as a result of that, the federal government is also able to then make certain rules in which states need to ensure that their Medicaid programs comply with those rules. So there are some baseline aspects of a Medicaid program that are generally pretty similar across states, because those are kind of the federal bedrock, the federal baseline of what Medicaid must do. But everything else from there is up to the state in question. And that's why every state Medicaid program is different. If you see one Medicaid program, you've only seen one. If you're an expert in one, you're only an expert in one, because every single one is different. And that's because the state has so much leeway on how it can approach its Medicaid program beyond just kind of that bedrock of federal requirements. So Medicaid is incredibly important to our community for a number of reasons. For one, many of those in the neuromuscular disease community are perhaps unable to work because of the disability or the disease that they indeed have, and so consequently they're not getting health insurance through their employer. Instead, they may be getting health insurance through their state Medicaid program. And if you're wondering what your state Medicaid program is, or if Medicaid might not be a particularly familiar name, it's because states oftentimes name their Medicaid programs different things. In Maryland, I believe that's where I am, it's called the Maryland Medical Assistance. In Tennessee, it's called TennCare. In California, it's called Medi-Cal. So, each state calls their Medicaid programs different things. So in addition to Medicaid being important to those with neuromuscular diseases, because especially for those who are not working or getting health insurance through their employer, oftentimes Medicaid is also the health insurer that is going to be covering home health care. It's going to be covering the personal care assistant or attendant who may be providing care to an individual with neuromuscular disease. In fact, Medicaid by far is the largest coverer of home health care in the nation, much more so than private insurance, much more so than Medicare. It's Medicaid that does that. So Medicaid, for at the very least these two reasons, but many more than that, frankly, is incredibly important to those with neuromuscular diseases. So let's move to the next slide. So we're also talking about Medicaid tonight because there have been some pretty substantial changes to Medicaid. Justin also already alluded to this earlier within his presentation. And these changes happened within legislation that goes by a couple of different names. There's H.R. 1, that's the kind of official bill number that this was named. There was also at one point called the One Big Beautiful Bill Act. But this was that really big bill that passed in July, that if you were attending our advocacy institutes, then if you were paying close attention to our advocacy, you were sending in stories on Medicaid, you were contacting your congresspersons, this was that really big bill that we were very active in trying to influence in the first half of the year, that then did eventually pass in early July. And I'll tell you, if you want a really good explanation on everything that was included in that final bill, you should go back and watch our Advocacy Institute from July. And Mark will be putting that in the chat here momentarily. We hosted that on July 15th, and that's where we walked through all the changes that legislation made. Now, there are several parts of this bill that will affect affordability to healthcare under the Medicaid program. The biggest thing this bill did, of course, kind of the top line thing, if you remember one thing that this bill did, is that over the next 10 years, it will reduce the federal government's responsibility for Medicaid by $1 trillion. Now, as I told you, the federal government covers anywhere from 50 to 90% or so of a state's Medicaid program expenses. If the federal government reduces by $1 trillion, the amount of money that's going out to states in Medicaid, that's a whole lot of money that is going to have a pretty big effect over the course of the next 10 years. And we'll talk about some of those effects here momentarily. But in addition to just the general reduction in spending that the federal government will be offering to states for their Medicaid programs over the next 10 years, this bill also enacted several policies that will affect the affordability of health care under Medicaid. So let's move to the next slide and let's talk about a handful of those. So there are some policy changes in H.R. 1 that directly affect the impacts, directly affect the affordability of healthcare under Medicaid. And there are also some that will indirectly, if you will, affect affordability of healthcare under Medicaid. I'll get to those next, but first let's talk about those policy changes that squarely affect affordability under Medicaid. The first is that there are now new cost-sharing requirements in Medicaid, but there are lots of caveats to this. It's not that every single individual under the Medicaid program will face cost-sharing requirements across the entirety of the health care that they may be receiving. So first, let's talk about the kind of health care. First, let's talk about what has been the case previously, and then I'll get into the changes. So historically, Medicaid programs have been allowed to opt in to cost-sharing requirements for very specific kinds of care, and there have only been really kind of a handful of states that have chosen to do that. I don't remember the exact number off the top of my head. I think it's maybe 7 or 8 states that have chosen to require limited cost sharing in specific instances within their Medicaid programs. And even in those handful of states, it's been shown that that has had problematic effects on those who use Medicaid and being a deterrent to actually utilizing healthcare, even if that cost sharing is comparatively minor. We're talking maybe $5, $10, $15 for a doctor's appointment, but sometimes that can really be quite impactful, actually, and if an individual is going to pursue going to the doctor or not. So now what we're seeing within the changes in Medicaid to cost sharing is now that it's no longer an opt-in for states to choose to implement cost sharing. Now it's a requirement. All states must now implement cost sharing within their Medicaid programs. But even still, as I mentioned, there are caveats. For one, it's not every single kind of access to care. There's a whole separate set of rules that govern cost sharing when it comes to prescription drugs. That has not changed, so we're not talking about that. And then there are specific kinds of care that are exempt from cost sharing. We're talking primary care, we're talking emergency care, we're talking ambulatory services, and also a handful of other areas that are carved out of this new cost sharing requirement. But for all the other ways in which healthcare can be utilized under Medicaid, there now may be anywhere from $1 to $35 per use of healthcare, if you will. So per doctor's visit, per appointment, per whatever. There could be an accompanied at a minimum $1, at a maximum $35 requirement of cost sharing. So obviously that can impact affordability. There's a very direct example of Medicaid affordability being changed this year under H.R. 1. Additionally, there is a change to retroactive coverage. Under previous Medicaid rules, if, let's say, I was eligible for Medicaid and I was eligible for up to 3 months prior to having actually gotten my Medicaid eligibility, my card, my number, my identification that allows me to go to the pharmacy, that allows me to go to the doctor and say, here's my Medicaid card, here's my Medicaid information, this is going to be my health insurance. If I had been eligible for 3 months prior to that, those 3 months would have been retroactively covered by Medicaid. I could have had the services if I hadn't paid for the copay, if I hadn't paid for whatever it happened to be from 2 months ago, that Medicaid would allow me to go back and have Medicaid cover those costs too. Now that has been changed within H.R. 1. That has been changed to the extent that it's no longer a 3-month look-back period. It's now a 2-month look-back period for people who qualify for Medicaid based upon their disability, based upon if they are individual who's pregnant, based upon those kind of factors. And if you have been eligible for Medicaid based solely on your income, and that income is anywhere from 100 to 400%, or actually 100 to 138% of the federal poverty line, that look back period is now only 1 month. So it's another way, again, in which affordability is affected under H.R. 1. The final thing I'll mention is that there's a moratorium on the Children's Health Insurance Program, or CHIP, program availability, which also may increase costs of care for kids who previously, and this is for new availability of the program, not current availability. There's not just a pause on CHIP. It's just there's a moratorium on states being able to expand their CHIP availability beyond where it is right now. So these are some of the direct impacts on Medicaid that H.R. 1 made as it pertains to affordability. But let's talk about some of those indirect impacts, and we can head there next. And this is where we're talking mostly about changes to accessibility of Medicaid in the first place, which will then have an effect on community members who may not be eligible for Medicaid any longer or may have trouble obtaining Medicaid. So, of course, there are a number of new eligibility requirements that were put in place under H.R. 1, which, if our community then is no longer eligible for Medicaid for some of these reasons, consequently, obviously that's going to affect the affordability of their health care. So let's talk about a handful of these. So one of the biggest ones to mention are the community engagement requirements, or the work requirements. These are one of the biggest features of H.R. 1. And this is a requirement for individuals who had qualified for Medicaid based upon Medicaid expansion. And let me pause just a second to mention what that is. That, again, is the provision of the Affordable Care Act passed in the late 2000s that expand Medicaid, or at least proposed to states that they should expand their Medicaid with largely federal dollars, all the way up to 138% of the federal poverty line. Previously, income had not necessarily been, at least across many states, a requirement for eligibility. This expanded Medicaid now said that anybody in that state that opts into this program, anybody at 138% of the federal poverty line and lower, is eligible for Medicaid. So that's what I mean when I say expanded Medicaid. So there, under H.R. 1, are now work requirements or community engagement requirements for individuals who access Medicaid based upon the expanded Medicaid provisions. Now, that is a bit of a gray area. It's kind of murky. It's not as if when I go to sign up for Medicaid, I'm put into one bucket or the other, the expanded Medicaid bucket or the non-expanded Medicaid bucket. No, it's just I would know if I'm eligible or not. And so it was a distinction that was made within the law that admittedly we're pretty worried about within the implementation of the law, because there may be many of our folks in our community swept in to those who are going to be expected to have to comply with community engagement requirements, even if they didn't necessarily qualify for Medicaid based on the expanded Medicaid criteria. So it doesn't give us a ton of comfort that that was one of the stipulations that Congress put in place. Now, there are also others. For example, Congress did put within the legislation that those with disabilities are intended to be exempt from work requirements. Also, family caregivers are intended to be exempt from work requirements, and there are a handful of other categories of exemptions as well. Now, the problem with this, though, is that this is something, again, that's happening right now. It was actually just the other week, maybe last week, when the Centers for Medicare and Medicaid Services announced the first guidance to states on how they're to implement this new program prior to this time next year, which is when this new program officially takes effect. What states now need to figure out is how those with disabilities are to prove to the states that they are disabled so that they don't have to comply with these community engagement requirements. And same goes for family caregivers. And sadly, we expect this to be a mess and a half when it comes to states trying to figure out some kind of system in which our community and any other community of individuals who are disabled are going to be able to prove to their states that they are exempt from these work requirements or community engagement requirements to maintain their Medicaid. And frankly, that's a whole additional advocacy institute that frankly we're probably going to have to do at some point next year. The point here, though, is that these new requirements will certainly affect the affordability of healthcare if someone is kicked off the program because they were lumped into having to comply with these requirements. Something went wrong. They lost their Medicaid. This has already happened, unfortunately, within states that have tried this out. This happened in Arkansas when Arkansas tried this out. And that it was looking like this could also be happening in Georgia potentially as well, as they've been going in this direction. So we'll have to see how this works, more broadly speaking, as this is implemented next year and going into following years. Now, there are also eligibility requirements that were changed for immigrant communities. Again, we're not talking naturalized citizens, as was mentioned previously, but for some immigrant communities that previously had been carved into Medicaid, they are now carved back out. Additionally, we're worried that with that $1 trillion that the federal government is now no longer going to be spending on Medicaid, that states will be limiting the eligibility for their program. And so eligibility limitations that we don't even know what they're going to be yet, because this $1 trillion cut is only scheduled to start in 2028. It's not even scheduled to start next year, not even scheduled to start the year thereafter. It's scheduled to start in 2028. Now, this being said, states are already starting to make some policy changes, seeing what's on the horizon. We've already seen some states move to change their reimbursement rates to providers, to clinicians. We're also expecting states to potentially limit waiver programs. These are the programs that are, by and large, optional for states to operate, in which they get, historically, a lot of federal money to help operate. And the most common of these are the home and community-based services waiver programs. But we are concerned that this is where states may look to limit the cost of their Medicaid programs to cover the budget shortfall that the federal money no longer being there will result in. So consequently, this is another area in which we can see affordability potentially being affected, in that states will have to choose to no longer offer certain waiver programs because they just simply can't afford to do so any longer. So with that, I think I don't know if I have another slide from here. I think I might be done. Let's move to the next slide. I am done. So that's the summary of the affordability challenges that may be coming for those who rely on Medicaid. And I'll be happy to take the questions that I see within the chat, but we're going to actually take those at the end after we've already mentioned Medicare and employer-offered health insurance. So with that, I'm going to hand it over to Joel to take over for Medicare.
Yep. Thanks, Paul. So we're going to start with Medicare. And kind of as a similar level set, I just want to go over really quickly what are the various parts of Medicare. So there's Medicare Parts A through D. Part A is inpatient hospital coverage. So whenever you are in a hospital, Medicare Part A is what is covering your healthcare costs there. Medicare Part B, as in boy, are things that cover your outpatient costs, like outpatient doctor's visits, labs, things like that. Medicare Part C is what's known as Medicare Advantage, which we'll get into very briefly, but it is a private insurance run, all-in-one private plan that bundles together Part A and B, and then usually adds in Medicare Part D, as in dog, which is usually vision and dental, but more specifically, prescription drugs and things of that nature are covered under Medicare Part D. So with that quick level set, we can move on to what changes are coming to Medicare in the coming months to year. So the big change to Medicare that's coming is the Trump administration rolled out what they're calling the generous model. So the generous model, for those of you that are aware of it, is very similar to the gene therapy access model. It is a voluntary program that works with both states and pharmaceutical companies to have them negotiate with the federal government over pricing of their therapies. It's going to cover a lot of, but not all, therapies that are currently available. The current request for contracts asks that manufacturers provide a price for all single source and innovator multiple source therapies, as well as associated codes by the manufacturer. So that's a fairly large swath of therapies available. And basically what happens is they would contract with those drug companies and work with states on coverage criteria, both to work through how those therapies would be covered. So basically trying to pin coverage criteria to as similar as possible coverage requirements for things like prior authorization, preferred drug listing, and things like that. To be as similar as the market rate as possible. And then they're going to try to pin the price to most favored nation pricing, which is basically attempting to pin costs for therapies to something as similar as other similarly situated countries throughout the world pay for their therapies. So when I kind of talk people through stuff like that, I kind of encourage them to think of other G5 countries. So countries like the United Kingdom, places like that are kind of going to attempt to be similarly priced here in the US. Now, there are potential challenges to that on a couple of different axes. So the first big axis is, those of you who might be familiar, that the Trump administration tried this when they were in office the first time through their most favored nation program. At that point, it was not going to be a voluntary program, which is honestly probably the biggest distinction between this attempt and the last attempt. But nonetheless, it was challenged in court last time, and the administration was not able to overcome the legal barriers that were challenged there. So it's possible that even though this is a voluntary program this time, there may still be additional legal challenges for their implementation of this model this time around. The other big challenge is that larger pharmaceutical companies may be able to find their way through the general tangle of attempting to negotiate with states and the federal government over how those therapies will be priced and how they'll move through prior authorization and things like that. But for smaller biopharmaceutical companies particularly, this might be particularly difficult for them to navigate. So it's possible that they may opt out of participating in this model, which may pose various problems for them and the program as we kind of move forward. As all of you know, there are often very small biopharma companies that provide therapies to our community and others as well. So they are, despite being smaller, a very important piece to that therapy, to that ecosystem. In terms of timeline, the request for applications has already gone out here in 2025. The negotiation will then kind of be worked up and start in earnest in 2026, and then I would kind of expect the bulk of that implementation process to happen between 2027 and 2030. So we still have a little bit of time in terms of when we'll likely see a large amount of the pricing changes happening over the next couple of years, but it is something that we wanted to highlight here, as it is going to be a fairly large percentage of therapies kind of covered under Medicare as we move forward. The other thing that we wanted to very briefly cover is on sequestration, and you'll see that second bullet that is, it's not something that we want to take up a whole lot of your brain, but it is something that we wanted to talk through very briefly here. And so sequestration, there we go, I can talk tonight, is a process by which it's a mandatory budgetary process that was brought about by the passage of another bill from a couple of years ago that basically says that when the federal spend occurs, there are various mandatory cuts to various government programs. One of the areas of mandatory cut is to the Medicare program. $500 billion would in theory be cut from Medicare if various steps aren't taken. I know that's a very shocking number, but the reason that we're not as worried about that as we could be is that there are various levers that Congress can pull and has been pulling since the passage of H.R. 1 that has kept the sequestration process from taking place. So one thing that Congress can do is Congress can basically just tell the senators for budgetary policy to ignore the Medicare piece of this and continue moving forward with other cuts to other areas. The other thing that can happen is they can write in, as they have been doing, various fixes to the budgetary bills to, again, remove Medicare from those calculations. And that's what's been happening as we've seen the government shut down and then reopen with a new budgetary package, and what will probably happen again at the end of January as we come up against another one of those budget negotiations is Congress will just write in to the budget and say, ignore sequestration until this budget comes up again. So again, could be a fairly substantial change if it were allowed to go through. But as of right now, Congress has been fairly diligent about taking that piece off of the table. So it's something that we wanted to flag, but not something that we think is worth spending a whole lot of time on. The other thing, and I'm going to go a little bit out of order here, but there are a couple of other things to cover with H.R. 1's changes to Medicare. So the big thing that that was changed in Medicare under H.R. 1 was their change to the low-income subsidies for folks. And there are kind of two big things that happened here. Is that one, the law blocked the Secretary of Health and Human Services from implementing a 2023 final rule until 2035 that required states to streamline enrollment in programs for lower healthcare costs for beneficiaries, particularly for those of low income. This included Medicare savings programs and low-income savings programs. The big place that this will hit a lot of folks is in Part A and Part B premiums and cost sharing. The other thing is that it lowers the low-income subsidies potential for Medicare Part D recipients. So in addition to the out-of-pocket maximum cap of $2,000 that we'll talk about here in a second, the low-income subsidy also helped folks that were of lower incomes pay for their prescription drug prices. That floor for who qualifies for low-income subsidies has been raised. The other thing to note, as has been noted several times throughout this evening, is that those that are deferred action immigrants and other populations of immigrants have been blocked from receiving Medicare low-income subsidies as well. So again, just a lot of different forces redrawing lines around who is eligible to receive various benefits under Medicare Part D specifically, but also Part A and B to some extent. So stepping back out away from H.R. 1 just very briefly, it's worth noting the continued shrinking of the Medicare Advantage market. This is something that Republicans in Congress have been very keen to shift folks over into Medicare Advantage plans. And the reason that they like this model is that it's a very streamlined model. So there tends to be less moving pieces and less policy areas to keep track of. The thing is that when Medicare Advantage was first conceived of, folks had many options in terms of what Medicare Advantage plan they wanted to participate in. However, as time has gone on, insurance companies offering Medicare Advantage plans have shrunk to the point that there are some states that offer Medicare Advantage that now only offer maybe one or two plan offerings for their recipients, which leaves people with a lot less choice around cost for what they are paying for in terms of premium and cost sharing for their Medicare Advantage model, again, for Part A and Part B. So that could potentially have a squeezing effect on what people are paying in their Medicare Advantage premiums because they now have so much less choice in the insurance offerings being offered to them via Medicare Advantage. And again, we'll dig into kind of the vertical integration of those health insurance costs here in a little bit. There are also going to be some mild changes to what is going to be covered, and various potential changes to Medicare Part D here in a little bit. And this one hasn't quite been as fleshed out yet. The administration is still kind of working its way through the notice and comment rulemaking process here. But basically, the administration is contemplating changes to specialty drugs and how those are covered. Its technical correction to specialty tiering that is going to be happening over the next couple of months that involves the value of therapies that are 10% or below the prior year, replacing an increase in modifiers. So that's just kind of a complicated way of saying there's going to be some amount of cost changing for specialty drugs. There's also going to be a certain amount of changing in the transparency of what prior authorizations are going to be happening in Medicare Part D. And there are also going to be some changes in the Medicare drug pricing negotiation around therapies there. We're not super concerned about that negotiation process, as none of the therapies that we are paying attention to are in the negotiation class, but we did want to mention it nonetheless. And then the last thing to mention on Medicare specifically is that low-income subsidies and the smoothing mechanism, the out-of-pocket maximum of $2,000 and the smoothing mechanism for that $2,000 cap are now fully in place. So during the Inflation Reduction Act negotiations, there was passed a $2,000 out-of-pocket cap for folks in Medicare Part D program for their prescription drugs. Obviously, that's really great for people that have a higher cost Medicare Part D therapy coverage. And then basically what the smoothing mechanism allowed is it allowed for someone to spread out that $2,000 cap across the year. So let's say that in January, you just had a very, very expensive drug that you had to pay for, and that was going to hit your $2,000 out-of-pocket cap. Now, rather than having to pay for that $2,000 all at once, you can spread that $2,000 out across the entirety of the plan year rather than having to pay it all at once. And that's now been fully implemented across several years, so there shouldn't be any hitches there. And so with that being kind of all there is to say on Medicare, we can shift over to the private insurance market from an employer-sponsored lens here. So why is the private insurance market a concern generally, as so many folks receive their health insurance through either the ACA or Medicaid or Medicare? Well, first of all, there are a fair number of folks in the community who do receive health coverage through their employer. So it's important there. But then also, health insurance companies these days are incredibly vertically integrated. And what that means is that they're providing health insurance along a lot of different axes. So for example, you might have a Blue Cross Blue Shield plan that you purchased through the marketplace. Blue Cross might also be acting as a Medicare, as a MCO for a Medicaid plan. So basically they're acting as kind of the shell for what is covered under a state's Medicaid program and are kind of helping out with what therapies are covered and how and what prior authorization is required. For example, as we've already covered, Medicare Advantage plans are just private insurance plans. So a Blue Cross Blue Shield insurance plan may be providing a Medicare Advantage plan in any given state. And then obviously, there's also the private insurance market. So an employer may also purchase insurance coverage through Blue Cross as well. So as you can see, it's entirely possible for an insurance plan to be providing coverage to folks across insurance types, regardless of how they technically receive that coverage. And the reason that that's particularly important is insurance as kind of a scheme is basically just a giant series of risk pools. So what it relies on is it relies on a diverse pool of folks being inside of their insurance plan. So there are a set of folks who are going to be incredibly healthy and will pay into having insurance, but won't ever actually use it. And for those folks, the benefit of insurance is just to have that safety net, such that if they ever needed to go to the doctor, then they would have health insurance to keep those costs down for themselves. Or if they ever, say, fell and broke a leg or something, then in that kind of emergent case, they would again have insurance to kind of fall back on to receive health insurance and benefit and cost lowering there. But in terms of those very, very healthy people who, all things equal, probably wouldn't ever tap their insurance for a year, insurance companies love those people because they're just getting money from those people without having to pay them out any benefit on the back end. And that kind of helps, for want of a better word, subsidize the folks that are going to be higher cost folks that also pay into those insurance markets, but are then going to ask the insurance company to pay for some of their medical costs, which are going to be mostly folks in our community who need to go to the doctor, who need to receive therapies, who maybe have an emergent health issue at some point along the year. They are duly paying into their insurance program, and so have a right to that healthcare coverage, obviously. But it's actually those more healthy people that are kind of subsidizing, in very much air quotes, that care for them because they are paying into the system without pulling from that system. And so what we may see with folks who are saying, wow, my health insurance increased by 100, 200%. I can't really afford that. Maybe I can risk, not buying into an insurance program and just kind of going from there. And what that does is it destabilizes the risk environment that insurance companies have created for themselves. And so if we see a whole bunch of people exiting the insurance market, insurance companies will then compensate by increasing their premium costs, for example, or saying, we're a little bit more reluctant to cover that high cost therapy. So maybe we throw a few more prior authorizations in the way before we're willing to write the check to cover that therapy, for example. So particularly because of the very interconnectedness of all these insurance plans, and then layer in on top of that the fact that people are going to see these, vast increases in healthcare costs, it's entirely possible that we start to see a lack of stability in insurance markets, which then maybe, again, impacts healthcare prices. And this is kind of what Justin was getting at with that first question from the night that I was alluding to as well, is that it's entirely possible that if insurers see enough volatility in their marketplaces that they start to make differing decisions about how they cover things and at what costs they cover things. But as for right now, what we're seeing is a fairly stable insurance market. And so we're not anticipating, or nor do we want to telegraph, massive changes to the insurance market. But it is something that's worth bringing up for sure. And then the last thing that we wanted to cover here is some changes to medical debt and how that interacts with credit scores. So the CFPB, or Centers for, I'm blanking on what CFPB, Centers for Policy and Budget Priorities, I'm sorry, that's not right either. Anyway, point being, CFPB is putting out a guidance document that basically says that they think that under the Fair Credit Reporting Act, it was illegal for previous administration to basically say that credit reporting agencies are not allowed to consider medical debt in their calculation of what your credit score is. Very briefly, a guidance document versus a proposed rulemaking. A guidance document is just an agency saying, this is how we think the law should be interpreted, but it does not have the full force and effect of a regulation. So it is not binding, legally speaking. It is just them telegraphing to outside actors, this is how we interpret the law so that you can go forward and make decisions about how you would like to implement various things accordingly. So they are telegraphing to credit rating agencies, we don't think that we have the power to stop you from considering someone's medical debt in the calculation of their credit score. And so it is very likely that we will see credit reporting agencies start to factor in if you have medical debt impacting your credit score, which then impacts your ability to get a loan for any number of other things. So that's really on the axis on which that's going to be most impactful for folks, as if you wanted to say buy a home, then that could maybe be impactful, or car loans or things of that nature could potentially come into play. So as you're kind of thinking through questions, I want to pass it over to Paul for some good news, thankfully, that's come out of Washington in the last couple of days while we skim the chat for questions.
Thank you, Joel. And I know we only have a minute left in our hour, so I'll be very brief. But just to show you the power of the advocacy, the impact that we can have as we all come together, I just wanted to take a second to acknowledge the win that we collectively had yesterday when Duchenne muscular dystrophy was added to the newborn screening recommended uniform screening panel. That's Secretary Kennedy signing the proclamation, if you will, there, signing Duchenne into the recommended uniform screening panel, and that means that Duchenne should be screened for at a birth across all 50 states sometime in the next 3 to 5 to 10 years. It can take a little while for states to catch up, but this was the official start of that process. So that changes the course of history for those in the Duchenne community, where the diagnostic odyssey in the not so distant future will officially no longer be a thing. So just wanted to add this in here because we talked a lot about wonky policy tonight and things that might sound kind of scary about healthcare prices or affordability being a greater challenge. When we come together and advocate, we make a difference. So with that, let's take your questions.
There we go. So since my long-term care insurance is changing in January, my mom is a primary caregiver. Will she be affected by not working for me? It's possible, but I wouldn't think so, at least not right off the bat. There is some possibility that waivers will be affected, but in the coming year. But I think it's much more likely that we won't see that change until a few years down the line. Can Medicaid programs help people with disabilities pay for medical equipment? Yes. Again, it varies state by state, depending on what exactly your state is willing to cover. But by and large, durable medical equipment is covered by state Medicaid programs, especially for those large pieces of DME. So things like wheelchairs, Hoyer lifts, things of that nature are usually covered by a state Medicaid program.
You have one more question that I see here, Joel. This is from Jennifer Lane. She says that she lives in Alabama. Alabama is one of 2 states that don't participate in Medicaid buy-in, and that if we could point her in the right direction to advocate for this. Medicaid buy-in, for those of you who aren't aware, is a state program that allows those with disabilities who are working to still be able to work while being able to buy into Medicaid, if you will, to then still access Medicaid, but be able to work at the same time, not have as strict asset limits. Jennifer, that is very much, at least in my familiarity, Joel, you correct me if I'm wrong, that is a state decision. So I would be sending you straight to your state lawmakers, your state representative or delegate, your state senator, to talk to them about this. I'm sure it's not new within Alabama. I'm sure you're not the first person to wonder why Alabama does not have a Medicaid buy-in program. So define the movement to try to have Alabama add a buy-in program is the place to go there.
I would very much agree. I think Medicaid buy-in is a great option for a lot of folks, but it is very much a state-specific thing. So I would talk to your local reps about that one. I don't think I see anything else. Hearing and seeing none, I think we will wish you a very nice evening and happy holidays to all of you. And we'll see you in the new year at some point.
Hey, everyone.